Good evening all. Thanks Nikhil and thanks Amol. Thanks Horizon for hosting the meeting, and thanks Eli Lilly for the opportunity. So next. So we are talking about a mutated EGFR, we are talking about NSCLC, and we are talking about a treatment naive situation. So does one size fit all? So we are into a situation in 2021. So we are debating that probably we have different treatment armamentarium for a different EGFR. So what information will help improve our treatment decisions? Next. So this is the slide every medical oncologist knows. The first box is a first generation TKI. The second box is the second generation TKI, and the third one is the third generation TKI. So all the first generation TKI are compared with the chemotherapy backbone. We see that there was a modest responses, modest PFS, but none had an improvement in the OS. Coming to the second generation, so second generation was again against the chemotherapy, except the Archer 1050 with dacometinib, which was against the first generation TKI. Again, so no much, yeah. So we can see the in the responses. So again, improvement in PFS, but again, no much in OS except a subgroup of a different EGFR in both Archer and the Lux lung. Coming to the FLORA, that was the third generation osimertinib, which was again compared with the first generation EGFR TKI. So we can see a responses, again a modest PFS. So there was around 7 months of OS benefit. Next. Coming to the first line TKI combination. So that was a single agent and TKI combination. So the first paper from our alma mater, Dr. Kumar Pravas and Banita. So gefitinib versus gefitinib with pemetrexed platinum. So overall responses improved, PFS improved, and we are yet to reach the median OS. But the trend towards improvement in the OS, and that was also true for the others, Japan and the Chinese trial. And we'll be talking more about this, the relay, what Dr. Amit will be talking about. So these were chemotherapy with, and this was anti-VEGF with first generation EGFR TKI. So improvement in responses, PFS, and we'll look at so what happened to the OS in the subsequent presentation. Next. So now we know that exon 18, 19, 20, 21. So these all are going to behave. So the upper one box, so 19 and 21 almost constitutes 89 to 90% of the EGFR lung cancer population, and rest 10 to 12% is contributed by 18 and 20. So today, if we try to segregate 19 and 21, it is just like a metastatic colorectal cancer. So we know that in metastatic colorectal cancer, left-sided tumors are better. So in the left-sided lung, so we'll get more of exon 19. In left-sided colon, we see a more of a younger population. So in exon 19, we'll see on the left-sided younger, while in exon 21, it is more in the right side and the older population. Next. So this is whole of 18, 19, 20, 21. We can see, so the majority we see is a exon 19 and followed by 21, and then rest is contributed by the 18 and 20. And this, we know that they are seen either in the never smokers or former smokers, adenocarcinomas, female, Asian group. Next. So coming to the indirect meta-analysis in the PLOS one, so 6 studies, around 1400 patients. So these were compared first generation and the second generations. It was compared with the chemotherapy. So significant reduced risk of disease progression for exon 19 as compared to the exon 21, that was L858R, with the overall HR of 0.59 and a significant p-value. Next. Coming to a direct meta-analysis, again in the PLOS one, 7 studies, around 550 patients. So first and second generation EGFR TKI compared with chemotherapy. Again, there was a significant reduced risk of disease progression for exon 19 as compared to the exon 21. Next. So coming to these important slides, on the upper half, you can see, so all this relates to exon 19 and the lower half relates to exon 21. So FLORA, if you say this, type to see exon 19, so the benefit of that osimertinib was 21.4 PFS, whereas with afatinib 13.8 and with the first generation EGFR TKI 11 and 16.5 with the Archer dacometinib. And in exon 21, we can see, so they have not fared like what exon 19 had. So 21.4 in the exon 19 with osimertinib, while in the exon 21, it was 14.4. And you can see with afatinib 10.8, with erlotinib 8.4, with Archer 1.1050, it was 12.3. So it means that in patients with exon 21 mutations, median PFS has yet to exceed 14.4 months, which was seen in the FLORA with osimertinib. Next. So with afatinib, both the Lux Lung 3 and Lux Lung 6, if we take combined OS, again you can see the deletion 19 did better than the L858R. So overall survival was improved for patients with deletion 19. The absence of an effect in patients with L858R suggests that EGFR 19 is a different biological disease with L858R. We will see that L858R, that is exon 21, usually is less sensitive like the exon 19, and this in the around 40 to 60%. So 60% more co-mutations happens with exon 19 as compared to exon 19. So that's why, so they are biologically different. Next. Coming to the OS in the FLORA, you can see a little better benefit in the L858 subgroup. Next. Coming to Archer 1050, so we can see a modest PFS 12.3 in the exon 21 subset as compared to 14.7 in the ITT population. Next. So coming to the relay, so the PFS in exon 19 and exon 21, we can see, so 19.6 and 19.4. So this is probably the highest what we have seen with the other anti-EGFR. Next. So coming to uncommon EGFR mutation, that is exon 18. Next, we know that till today the data favors afatinib. So overall response rate 2 out of 3 is going to respond to afatinib. If we have an exon 18, duration of response at 1 year is around 1 out of 2, and duration of response at 1.5 years is 1 out of 3. And probably second drug in osimertinib, though we have a response rates and PFS much lesser than afatinib at this moment. Next. Coming to exon 20, so probably this is a refractory EGFR at this moment. So probably some drug like poziotinib, which is a novel inhibitor of EGFR and HER2 exon 20. So probably it will in time to come, it will have in practice. So overall response rate 55% and a median PFS of 5 to 5.5 months with a hard to treat disease in the EGFR sequence. Next. So to summarize, exon 19 deletion, so probably is usually seen in the left lung, younger patients, they have a less concomitant mutations and more sensitive. Historically, this subgroup has achieved better outcomes. Both third and second generation have demonstrated substantial PFS benefit. Exon 21, so which is the most discussion today. So median PFS had not exceeded 14.4 months, what we saw in FLORA with osimertinib. So promising results in the subgroup from relay with bevacizumab, with Cyramza and erlotinib. Uncommon EGFR mutations. So at this moment, afatinib scores over osimertinib. Exon 20 at this moment, we have to go with chemotherapy till we have poziotinib in hand. Next. So first generation TKI followed by osimertinib in T790 mutations. So many a times affordability. So second generation TKI, most of us follows because we know that most of our patients cannot purchase the original osimertinib and osimertinib on progressions, and osimertinib in first line EGFR mutated non-small cell lung cancer attains the maximum, but again a costly drug, but definitely prevents brain metastasis. And for a young fit patients like the TMH trial, so chemotherapy with first generation TKI can improve PFS, OS, but at the cost of some amount of toxicities. And we are looking at a new combination of a TKI VEGF, especially for those patients with exon 21 mutations. Next. So this is the landscape of EGFR mutation and how we can sequence in future. Thank you so much.